Group 2's Week 5 presentation will focus on that of Graves' disease. Group 2 members are Leslie Fernandez, who talks of what is the disease and risk factors. Stephanie Hallister outlines diagnostics and patient outcomes. Joseph Eliason is in charge of final formatting and the video presentation. Courtney Holcomb introduces the group and does the narration. Callie Everett outlines treatments for the disease. June Garcia does the pathophysiology. Kimberly Theowis developed the case study. Rosalind Domingo talks about the complications and the signs and symptoms, and James Gaynor outlines the pathogenesis. A 27-year-old woman presents to her primary care provider because she has had a recent bout of diarrhea lasting 5 days. Over the last year, she has had several bouts of diarrhea, but none lasting this long. Over the past 3 months, she has had a 20-pound weight loss, but her diet has not changed. She has occasional times where she gets very hot and sweats profusely, as well as having heart palpitations at random times. Upon physical examination, it is noted that her eyes are puffy, her blood pressure is 149/89, and she has a fever of 100.5. Palpation of the thyroid shows that it is slightly enlarged. She is a current half-a-pack-day smoker with no known drug allergies. Lab results show a low TSH of less than 0.01 and a free T4 of 35. An ultrasound of the neck was also performed and shows a multinodular goiter slightly larger on the left side. Graves' disease is an autoimmune disorder that results in overproduction of the thyroid gland. Graves' disease is the underlying cause for 50 to 80% of all hyperthyroid cases and is more common in women than in men. A person who has a family history of a relative with Graves' disease increases the person's chance of developing the disease. According to the Mayo Clinic, Graves' disease most likely has a gene that is responsible for or can make a person more susceptible to this disease. Graves' disease usually affects people under the age of 40 and is more common in women than men. People with other autoimmune disorders such as type 1 diabetes are at an increased risk of developing the disease. Pregnant women or women who have recently given birth and who are genetically susceptible are also at an increased risk. Cigarette smoking, which also affects the immune system, and emotional or physical stress may trigger the onset of Graves' disease. If Graves' disease is left untreated, many complications may occur, including osteoporosis, heart disorders, pregnancy complications, or thyroid storm. Having too much thyroid hormones can interfere with calcium in the bones, which can lead to brittle and weak bones. The heart structure and function of the muscles start to change, causing arrhythmias, which can then lead to congestive heart failure. During pregnancy, preeclampsia, miscarriage, preterm birth, and fetal thyroid dysfunction may occur. Thyroid storm is a rare but life-threatening complication of Graves' disease, also known as accelerated hyperthyroidism or thyrotoxic crisis. It is more likely when severe hyperthyroidism is left untreated or treated inadequately. The sudden and drastic increase in thyroid hormones can produce a number of effects, including fever, profuse sweating, vomiting, diarrhea, delirium, severe weakness, seizures, irregular heartbeat, jaundice, low blood pressure, and coma. Thyroid storm requires immediate emergency care. Graves' disease is classified as an autoimmune disease and results from a form of type 2 hypersensitivity in which there is infiltration of lymphocytes and stimulation of the thyroid by autoantibodies directed against the TSH receptor. These autoantibodies, called thyroid-stimulating immunoglobulins or TSIs, override normal negative feedback mechanism. The TSI stimulation of TSH receptors in the gland results in hyperplasia of the gland, or a goiter, and increased synthesis of TH, especially of T3. Increased levels of TH affect every physiological system and result in the classic signs and symptoms of hyperthyroidism. TSIs also contribute to two major distinguishing clinical manifestations of Graves' disease, ophthalmopathy and dermopathy. According to Pockrell, Graves' ophthalmopathy is caused by inflammation, cellular proliferation, and increased growth of extraocular muscles and retroorbital connective and adipose tissues due to the actions of thyroid-stimulating antibodies and T lymphocytes or killer cells. These cytokines and thyroid-stimulating antibodies activate periorbital fibroblasts and pre-adipocytes, causing synthesis of excess hydrophilic glycosaminoglycans and retroorbital fat growth. Glycosaminoglycans cause muscle swelling by trapping water. These changes give rise to proptosis, diplopia, congestion, and periorbital edema. If left untreated, it eventually leads to irreversible fibrosis of the muscles. Other signs and symptoms of Graves' disease include pretibial myxedema, thyroid acropathy, enlargement of the thyroid or goiter, increased appetite, hyperactivity, fatigue, and weight loss. Graves' disease is an autoimmune disease considered to be an underlying cause of 50 to 80% of cases of hyperthyroidism, mostly affecting women. It is marked by a goiter, which is a diffuse enlargement of the thyroid gland, tachycardia and heart palpitations, protrusion of the eyes from the orbital cavity, low thyroid stimulating hormone, and high thyroxine levels, all of which are symptoms of thyrotoxicosis, the body's excess of thyroid hormone production. It occurs when antibodies such as thyroid stimulating immunoglobulin and thyrotropin receptor attack the thyroid gland, leading to an overstimulation of thyroxine, the hormone that controls the body's metabolic rate, thereby increasing the body's metabolism by 60 to 100%. Environmental and genetic factors contribute to the development of Graves' disease, such as pregnancy, excess in iodine, infections, stress, smoking, and interferon alpha trigger immune responses to susceptible genes. The thyroid gland is a butterfly-shaped gland located on the lower interior neck below the larynx, hugging the trachea. It produces T4, which maintains the body's metabolism, and T3. Large amounts of T4 in the bloodstream is converted to T3, which has a faster onset of metabolic action on the cells. Thyroid hormone production is controlled by the pituitary gland. The brain's hypothalamus produces thyroid-releasing hormone, which signals the pituitary gland to either release or inhibit the release of TSH. The TSH signals the thyroid to release thyroid hormones, especially when there's an insufficient amount of T3 and T4 in circulation. When there's an elevated level of T3 and T4, the pituitary gland inhibits the release of TSH to regulate the amount of thyroid hormone in the body. The oversecretion of thyroid hormones are due to the antibodies thyroid-stimulating immunoglobulin and thyroid-stimulating antibody, which override the normal regulatory mechanisms of the thyroid gland. Environmental and genetic factors stimulate the T lymphocytes to stimulate the B lymphocytes, which primarily synthesize the TSI, which becomes sensitized by antigens in the thyroid gland, immobilizing the antigens. The TSI binds with the TSH receptor on the thyroid cell membrane and mimics the action of TSH, stimulating both thyroid hormone synthesis and thyroid gland growth, leading to hyperthyroidism and thyromegaly. Diagnosis begins with discovering if there is any family history of any thyroid disease, especially Graves' disease. During the physical exam, look for signs and symptoms of Graves' disease, such as irritated or protruding eyes, enlarged thyroid, tachycardia, and signs of tremor. Blood tests used to help diagnose Graves' disease include thyroid stimulating hormone levels and thyroid hormone levels. In Graves' disease, TSH is low and the thyroid hormone is high. Radioactive iodine uptake can also be used. Iodine is needed for the production of thyroid hormones, and a high uptake can indicate Graves' disease. This may be combined with a radioactive scan to trace the uptake pattern. Ultrasound can be used to see if the thyroid gland is enlarged and also if iodine uptake cannot be used, such as in pregnant women. CT scan or MRI can be used to visualize the thyroid gland. Fine needle aspiration biopsy may be performed to rule out thyroid cancer. Initial treatment of Graves' disease focuses on symptomatic relief. Common bothersome symptoms of Graves' disease are tachycardia, palpitations, and tremors. Beta blockers such as atenolol are commonly used to control tachycardia and palpitations, while propranolol is used for tremors. Following a well-balanced, healthy diet and maintaining a regular exercise routine will help minimize other symptoms of Graves' disease such as weight gain and decreased bone density. The thyroid controls and regulates metabolism, and when the body is no longer in a hyperthyroid state, patients tend to gain weight. Frail or brittle bones are an associated side effect of Graves' disease, so continuing low-impact, gentle weight bearing can help promote healthy levels of bone density. Managing stress levels is important, as increased stress is known to trigger Graves' exacerbations. Treatment of Graves' disease also focuses on decreasing the synthesis of thyroid hormones by using antithyroid drugs. Antithyroid drugs are used in an attempt to achieve a euthyroid state for as long as possible until a more radical treatment is needed. Methimazole is a first-line antithyroid drug used to treat Graves' disease. Methimazole prevents iodine and the enzyme peroxidase from their normally occurring interactions that bind with thyroglobulin to form T4 and T3. This action decreases thyroid hormone production. Propylthiouracil works in the same way that methimazole does to decrease thyroid hormone production, but also converts T4 to a more potent T3. Propylthiouracil is used instead of methimazole if the patient is pregnant. Radioiodine ablation treatment. The radioactive form of iodine is orally ingested. The radioactive iodine is picked up by iodide transporter of the thyroid, mimicking the way that natural iodine is picked up. The thyroid processes the radioactive iodine, and the radioactive aspect of the iodine destroys the follicular cell of the thyroid, causing destruction of the overactive thyroid cells over a period of 12 to 18 weeks. A thyroidectomy is permanent surgical removal of the thyroid. This provides a cure from hyperthyroidism, and the patient switches from antithyroid medications to thyroid hormone replacement medications. Positive patient outcomes depend on early recognition and diagnosis of disease, appropriate treatment, patient adherence, and long-term follow-up. Our 27-year-old patient was started on methimazole treatment after her Graves' disease diagnosis. She was also placed on a beta blocker for symptomatic relief of her palpitations. Smoking cessation, healthy diet and exercise, and stress management techniques were encouraged to help minimize symptoms and decrease chances of exacerbations. Continued follow-up examinations to assess need for further treatment will be needed. Prolonged low-dose methimazole treatment is a safe and efficient alternative to radioiodine treatment. In one study, almost 40% of patients who underwent surgery or radioiodine ablation had little morbidity and few remission. Relapse predictors include factors such as smoking status, thyroid-stimulating antibodies before and after treatment, low TSH, goiter size, and stress events.